everyone to New Retina Radio Journal Club with VBS. My name is Lediana Goduni. I'm currently in practice at Retina Associates of Cleveland, and I'm joined today with two of my colleagues. First, we have Dr. Joshua Uhr from Retinal and Ophthalmic Consultants in Northfield, New Jersey. Josh, welcome.
Hi, Lediana. Thanks for having me.
And second is Dr. Matt Starr joining us from Mayo Clinic. Matt, welcome.
Hey, yeah, thanks for having me. I appreciate it.
So today we're discussing a very interesting topic that we don't often see in the retinal literature. The title of the paper is called Rates of Recurrent Retinal Detachment Following Vaginal versus Caesarean Deliveries, a Retrospective Analysis and Review of the Literature. The first author is Asaf Shemer, and this article was published online in Retina in August 2023. And Dr. Uhr is going to summarize the paper for us.
So the purpose of this study was to assess if vaginal delivery resulted in higher rates of recurrent retinal detachment compared to cesarean section delivery for women who have a history of retinal detachment. So this is a retrospective cohort analysis of patients who delivered a singleton baby at the Shamir Medical Center in Israel and who had a previous history of retinal detachment prior to that delivery over a 30-year period from 1990 to 2020. The authors considered 32 patients and 66 deliveries. None of the patients had any ocular history in the fellow eye, and cases were divided into two groups, vaginal delivery and cesarean section delivery. No differences were found in the two groups in terms of maternal age, gravidity, or parity, and the authors compared the rates of postpartum recurrent retinal detachment for the vaginal delivery group compared to the cesarean section delivery group. So what they found was that two patients in the vaginal delivery group and two patients in the C-section group experienced a recurrent retinal detachment after delivery for a rate of 5% in the vaginal delivery group and 7.5% in the C-section delivery group. But this difference in rates of recurrent retinal detachment was not statistically significant, and therefore they conclude that there is no ophthalmological benefit to C-section compared to vaginal delivery for women with a history of retinal detachment.
Great. Thank you so much, Josh, for that wonderful summary. I'd like to ask Matt for a quick reaction to this paper.
No, I mean, that's a great job, Josh. I think for me, the biggest takeaway is this does provide some additional, evidence. There's always been, a lot of anecdotal, things or hearsay about, requiring a vaginal delivery versus a cesarean delivery, which to me, it just didn't seem really intuitive. I think the paper and the discussion goes into some of the mechanics behind, the increased intrathoracic pressure and the raised intracranial intraocular pressure. And there's really no credence to that leading to retinal detachment recurrence. And they kind of, discuss that. And I think for me, this is a good way for us to kind of, provide some evidence as to why we really don't, have a really big say as ophthalmologists into what they want to do for the delivery. I think that's a big decision between them, and I think the retinal detachment rate should be something they would have to consider.
Great, yeah, and Josh, what do you think about Matt's comments to the paper?
Yeah, I mean, I agree with what Matt was saying about how this mechanism for how vaginal delivery could lead to retinal detachment does not really make much sense, right? The idea behind it is Valsalva, and that can lead to, they do talk about intraocular pressure being raised, but that's not what causes retinal detachment, right? You need a retinal break and from vitreoretinal traction that rips the retina, and then fluid gets under that break and sort of overwhelms the RPE pump. So it just doesn't make sense that Valsalva during delivery would lead to that. So I do appreciate seeing some actual data that kind of validate that this is not really a big concern.
Yeah, great. I think it's really important point to bring up because based on what this paper said and just logically thinking about the mechanism of detachment, that doesn't make sense. And, it sounds like a lot of the obstetrics and gynecological recommendations aren't really founded on, really good evidence. It sounds like it's just based on an old theory that has no real scientific support. So I agree with both of you. This is really good to have some data on this. And Matt, do you think that this study should, if at all, impact OBGYN consults to ophthalmologists for patients who are pregnant or about to deliver based on their ocular history?
I mean, I think if there's ever a question, bring on a consult. I wouldn't say they shouldn't consult if they really don't know or they're having concerns on how to, deliver or recommendations. Like, please shoot us a consult or please shoot the team a consult just to know. I think for us as an ophthalmologist and retina specialist, we can provide some, limited data, but some decent data, to suggest perhaps that there really isn't a risk for recurrent detachment, following either delivery method.
Great. Yeah, that's a great point. So we'll take a quick break now, and we'll be right back for a bit more of an in-depth discussion on this paper. Great. So welcome back to New Retina Radio Journal Club with VBS. I'm joined by Dr. Uhr and Dr. Starr, and we'll get into a little bit of a deeper discussion about our paper that Dr. Uhr just summarized. I'd like to ask Dr. Starr for some limitations to this paper.
No, I mean, as much as it is, helpful to give us some evidence, to help support some of our decisions when counseling patients, I think, the biggest takeaway for me is there was a lot of things that I really still I had more questions, after reading it. I wanted to know, what kind of surgeries or procedures were they, pneumatics, lasers, we were talking about offline, just, what did these patients have, or was there a different rate in outcomes based on the type of surgery? At least more detail on the 4 patients, I think would have been helpful. And then secondly, when did these surgeries occur? Are we talking, were these 5-10 years ago, or, the more recent, where they're at perhaps a higher risk for developing recurrent detachments?
Yeah, great. Yeah, those are really great points. Some more details regarding the nature of the detachments or their surgical repair would be really helpful here. And Dr. Uhr, anything to add based on that?
Yeah, I mean, I agree. I would like to know more details about those 4 cases. As Dr. Starr already pointed out, if these patients, if their original surgery was recently, immediately prior to the delivery, it would make sense that they're still within that period of having a higher risk for recurrent detachment. Whereas if the surgery was years prior to the delivery, then it is curious why they had a retinal detachment or recurrent detachment within, in some cases, days or weeks after the delivery. So that is interesting, and I do think that brings up some questions that weren't answered in the study. The other thing is, it's a very small sample size here. They just had just north of 60 deliveries. And obviously, this is a difficult thing to study because you're looking at a demographic of women who are of childbearing age and who have a history of retinal detachment and then go on to have a baby at the same medical center, no less. So hard to study this. So it's hard to get big numbers, but certainly that small sample size is a limitation. They had 2 recurrent detachments in each group, but if they had 1 or 2 more, that might totally throw off the statistics and change the conclusions.
Yeah, I know. It's kind of interesting. They had 30 years worth of data and 2,000 patients they went through, but they were whittled down to 32 patients and 66 deliveries. I mean, like you said, it's it's a hard thing to study. I think it would have, knowing some of the pre-op metrics, because were these patients, we can discuss more as these are tricky cohort to operate on. What do you do if they're pregnant with a detachment? That gets a little bit scary. Did you try to hedge your bet and do an LAO or something and avoid the operating room? Did you do something you maybe wouldn't have done because you couldn't get anesthesia? And so either way, you're going to run into some risk around the delivery time if you didn't do what you maybe normally would have done.
Yeah, difficult group to study just because it's not the most common circumstance, like you both said. They mentioned in the paper that, the recurrent detachments occurred about 17 and 26 days for the vaginal group, and then 5 days and 30 days for the C-section group. Do either of these surprise you guys, or do you make anything out of these delays in recurrent detachment after the delivery?
It's just, it's hard to interpret exactly what that means, or if there's any relationship to the delivery without knowing the history of those specific patients. When was the original detachment? As we kind of talked about it, it's a different story if the original detachment was a month before delivery versus 5 years before delivery. So really hard to interpret those numbers without a little bit more context.
Right, and that's a
Yeah,
good point. Certainly that highlights one of the limitations, of a retrospective study of spanning 30 years. Maybe they didn't have all this information either, but it would be nice to know. Matt, go ahead.
yeah, I was gonna say the same thing. I mean, I feel like this was a really nice starting point, but I'm still left with a lot more questions that would have, I think, could have really helped the paper if we had a little bit more background data on, the surgeries, the types of detachments, things like that, to help us. But I mean, it's a starting point. There's not a lot of data, as they state, and so this is, start.
Yeah, that's a great point. It's a good start for further investigation. I was actually a little surprised that the prevalence of OBGYNs that recommend C-section delivery versus vaginal based on ophthalmic history. Did that surprise either of you guys as well? Or what's your experience, with OBGYN consults? I mean, I've gotten consults in the past just with pregnant patients with vision changes, none of them related to detachments. But what is you guys' experience with that?
I think, I mean, I've had a few delivery consults, and it's more vision changes, and are they're looking for signs of preeclampsia, things like that would maybe push them over the edge to induce a delivery. I never would have thought that they would be basing a delivery decision on a history of a retinal detachment. And so I agree, it's usually in the setting of vision changes. And I was so surprised that the number of OBGYNs that would recommend a delivery based on eye findings, when it was 60-70% or something, compared to 0% of ophthalmologists
Yes.
in the survey studies.
Yeah,
Yes.
they cite a study here that it was a survey of OBGYNs in England, and 75% of the OBGYNs reported that they felt that a history of retinal surgery was an indication for obstetrics intervention during labor, so either forceps use or C-section. I was very surprised by that as well.
So having said all of that, are there any circumstances in which either of you think that you would offer any recommendations regarding mode of delivery? And I'll go to Josh first.
No, certainly not for a history of retinal detachment. I mean, I think that it's something that could that warrants consideration in patients, for example, with PDR, where Valsalva could actually rupture neovascular complexes and cause vitreous hemorrhage and other complications. I still wouldn't tell patients that they had to avoid vaginal delivery in that circumstance. Vaginal delivery is important to a lot of women, and advising them to use or to go to a C-section instead is a big decision. I mean, that's a major abdominal surgery, which has risks of its own. So I don't necessarily think that that's a contraindication, but I do think it might at least warrant a discussion with the patient that they could have some ocular complications, although even in that case, nothing that couldn't be handled after the delivery. And obviously in that situation, I would do what I could, PRP while they're pregnant to try to avoid those complications in the first place.
Yeah, that's a great point. And Matt, anything to add?
Yeah, I mean, one of my big takes on systemic consults for to us as a retina specialist is, if you're going to ask me if there's an eye condition that warrants changing some sort of systemic intervention, whether it's a blunt thinner, a delivery, my general response is, you do what's best for the patient. I can take care of the eyes after. I think if they're going to say, oh, if you have this, we have to do a C-section, we have some limited data that may support you could do either one, and they would do fine. From my standpoint, I can fix whatever you need to fix when I need to fix. You just do what's best for the patient from your standpoint. And I think that's been my response for most of them, and they kind of generally like that approach.
Yeah, I would agree with that. Josh?
Yeah, I agree completely. I think that makes, a lot of sense. It's I don't think that we are really in a position to advise women and OBGYNs whether or not they should have vaginal or cesarean section deliveries just based on their eye history.
Right. And like Matt said, we have lots of tools in our toolbox to fix most things that occur. So we're lucky in that sense. Well, I'd like to thank you both for your insights and discussing this paper. And thank you to the audience for listening to the new Retina Radio Journal Club with VBS. And stay tuned for further episodes.